Hey everybody, welcome to Tough to Treat, and this is Erica Mello, and we are at episode number 56. And before I give you a brief introduction to the episode, just wanted to make a small announcement. Susan and I are going to be hosting a one-day mastermind mentorship in February, the day before CSM starts. So the official start date, I believe, is the 13th. We are hosting a one-day mastermind on February 12th, which I believe is a Wednesday. And if you are interested, please email myself, Erica, E-R-I-C-A, at ericamello.com to register your interest. It's a great opportunity for all of us to get together, and as well as our listeners, and meet you all. But to discuss, bring us your patient scenarios, bring us your complex patients. We're formulating the details, but we're open to all questions, and we just want to help people, get better and learn more about how, learning how to treat the complex patients. So once again, just email me at erica@ericamello.com and let me know if you are interested, or just reach out to us on social media. So in this episode, we talk about a patient of mine who I've seen recently, and I've only actually seen her a couple of times. I wanted to discuss her because the first question that she asked me was, or the first statement actually was, I've had 4 visits of physical therapy somewhere else and I'm worse. Why am I worse? And I was like, I don't know. We have to figure it out. So I think this is a great lesson in exploring doing the wrong treatment. It may have been the right time, but it was the wrong thing to do. So I tell her and explain to her why her prior treatment at another clinic was not helping. And I think that really empowered her. And I think sometimes when we see some straightforward symptoms, we sort of rush to, I'm going to do this, this, and this. And it's not always the right thing to do. This patient wasn't so clinically complex until she got 4 sessions of the wrong treatment. So hope you enjoy it. Bye. Hey everybody, this is Erica Mello and Susan Clinton, and welcome to Tough to Treat. How are you, Susan?
I'm good. We had a few technical difficulties this morning, but I'm hoping that we're ready to go now.
I know, it's crazy. Oh my Lord. It's computers are good, but then, sometimes technical issues happen. I always wonder if it's Mercury retrograde when all this stuff happens, It's crazy. It's my turn today to discuss a patient. So do you want to just get started?
Yes.
Okie dokie. This is a patient I actually saw recently, very recently, as recently as last week for the first visit. And I thought it would be a good opportunity to just problem solve through why she came in to see me. And she had been somewhere else and wasn't getting better. And I've only seen her twice. But I think that when we see patients with low back pain or leg pain, and we kind of, not everybody, but some people jumped to, let's just treat the symptom. And this woman was not getting better. So I'll start. She actually is 80 years old. She looks like she's 60. I mean, she's in great shape. A little bit of a lot of fear with her. She came in to see me with a history of right hip and butt pain going into her upper thigh. So she would use her hand and run it down the outside of her right thigh. She felt pretty good walking, and the main issues were driving. So it was her right leg driving and going from sit to stand. Not so much the act of sitting, but going from sit to stand and then prolonged standing. So walking was pretty okay. She would throw these salon pause patches on, etc. Not really. A little bit of relief, but not really. So Her symptoms began 1 month ago. She came in to see me and she's like, I know when it all started. I'm like, oh, hallelujah. People are like, I don't know. You have to dig and dig and dig. But she's pretty healthy otherwise. So 1 month ago, she had a lot of dental work done. And it's funny, I went to the dentist yesterday for a checkup, and I'm thinking of how she was sitting in the chair. She was 3 hours in the chair for some dental work. And then she had to do a lot of driving, about a 3 hour drive to New Jersey. And then this is probably within a 2 day span. And then she had a cyst in her left foot, dermatologically removed. So just injected. It wasn't like it was painful, but when she was describing it, she was using these facial gestures like it actually did hurt. So a month ago, sitting in the dentist's office, then she drove 3 hours to New Jersey, and it's her right leg, and she had a cyst in her left foot, and she received a shot there, and it was quite painful. The shot was painful, not so much the after effects. She ended up going to see somebody else here in New York, a group practice, and went about 4 times. And her first question to me was, why didn't I get better? And I'm just backing up a second. She did end up seeing a physician prior to seeing the other physio, and he put her on a dose pack of prednisone. And she got no relief at all from it. And he said, start with PT. So that's when she started with the other place. So what they did was, according to her, obviously since I wasn't there, they did a lot of aggressive massage on her right side of her low back, into her glutes. They did a lot of she was describing it, knees to chest, lying on your back, hip flexion, cross, piriformis stretching, that type of thing. Pretty much over sort of stretching that lower right quadrant in the glutes and lumbar spine. So after 4 visits, she went back to the doctor, and she said she wasn't better, and he's like, you need go somewhere else, wherever.
Mm-hmm.
And which was, thank God, because a lot of patients would not go somewhere else. They would go see,
Mm-hmm.
another healthcare provider besides a physio. So a friend of hers who I'd seen before referred her to me. So just in terms of past medical history, and then I'll stop and you can comment. She has had a lot of women's health issues, actually. She had surgery for prolapse some years ago. She didn't remember the time, and her quote unquote didn't work. That's what she said to me. She's had some fibroids removed. She had a lumpectomy. I'm not sure which side. 5 years ago. She was on tamoxifen at that time. They put her on tamoxifen, and she had right foot surgery about 15 years ago for a bunionectomy, for a bunion and hammer toes. And in terms of medications, she's basically on, the only prescription is Lipitor, and she takes a lot of vitamins, CoQ10, omegas, things like that, vitamin C. Otherwise, her general health is pretty good. She sleeps on her side, and her symptoms are generally worse at the end of the day. And she has one episode of low back pain years ago that resolved on its own. And her main recreational form of exercise is walking, like a lot of people here in New York. That's
Mm-hmm.
all we do is walk. So I'll stop there and let me know if you have any questions before I get into it.
And she doesn't have any symptoms at all when she walks?
No, she doesn't. I thought that was interesting.
So she has symptoms when she sits for prolonged.
Well, she goes from sit to stand, so she can sit for an hour, right? But sit to stand bothers her. Yeah.
But when she drives, it bothers her.
Correct. And after the evaluation, she's like, "I'm really worried I'm not going to get back. You think I'll be okay?" So that's pretty much what she said.
And it's her familiar pain when she drives, like the same pain she gets when she stands up.
Mm-hmm.
And then how long can she stand before it comes on? Or does it just start there and it always is there?
No, she can stand a decent amount of time, probably like an hour, 30 minutes, probably. The worst was sit to stand and driving.
Okay, so whenever she goes up to standing, she has a jolt of pain. Is that
Yeah,
what happens?
exactly. A jolt of pain, and then she tries to rectify it, and she can rectify it after a minute. But
Uh,
I think the driving is what got her the most because she
yeah.
drives a lot.
So what does she do to rectify this?
She moves. She just
Okay.
moves.
Okay.
That's what she told
So,
me.
yeah.
So I've
Yeah.
seen her twice. This was the first visit. So so she moves. The standing, because I thought the walking would have aggravated it, but it did not. She can walk pretty okay. I mean, she told me if she walks like 30 blocks, yes, it'll bother her, but generally she doesn't usually walk that far here. Ironically, she does drive, and usually New Yorkers don't drive that much, but she does because she
Mhm.
has family out in the boroughs and in New Jersey.
Okay. So, when did she tell you anything about her prolapse surgery? Did they do a hysterectomy?
Yes, they did.
Okay, so they did and she said nothing worked because the prolapse is still there. If they took the uterus away, there's nothing left to prolapse
Right.
except perhaps the bladder.
Correct.
So, but she says that it was. I was wondering maybe she felt it was unsuccessful because she was having pain and it didn't correct the pain.
It could be. I
Yeah,
didn't ask her, and I probably should have, but I could certainly ask her.
yeah.
I mean, she was like, it didn't work. She was just so long ago, and she didn't remember. And I was like, okay,
Okay, yeah.
yeah.
Um,
She was not complaining of incontinence or anything like that. Uh, Otherwise, she seemed pretty healthy. Obviously,
mhm,
she had the lumpectomy and things like that. So a lot of women's issues, but
mhm.
um,
Well, a lot of these issues that she's had for her female stuff is a lot of estrogen dominance.
yeah.
The the fibroids and the
Hmm.
lumpectomy and that kind of stuff.
Yep.
But the tamoxifen took her. She was able to take the tamoxifen, so that kind of probably changed that just a little bit. Who knows where she is now? Okay, so what happened with the aggressive massage and the stretching?
So
When
basically,
she stretches, did that pain increase?
yeah, she got worse.
Okay,
She got worse, she said.
so
Yeah.
flexion for her is no bueno,
Right.
and so flexing forward to get out of the chair bothers her. Is the
Correct.
hypothesis I'm going with.
Yep. Yep.
Um, and if she sits in the car for long periods of time, driving with her foot stretched out,
Mm-hmm.
then that's what's bothering her too. So it looks
Mm-hmm.
like it's a kind of a if I had to categorize her at all at this point in time, it would be flexion is not the thing she needs to be doing. Um,
Correct.
so let's see what you found in your eval.
Okay, so what I did was I'd always do my center of mass, and she was way on her right leg, which, not surprising, I guess, because she had that
Mm-hmm.
foot issue. I mean, she didn't make a big deal about the system. Like, yes, but your brain subconsciously offloads. If I got a
Mm-hmm.
shot in my foot, I'd be on my right leg, for about a couple weeks. So
Mm-hmm.
it fell well, and that little piece of history fell within the time frame. So center of mass was way off to the right. She stood with a pelvic rotation to the left, and the right hip was anterior. So those are the glaring things that I saw.
Mm-hmm.
She had some issues in her right foot. For example, she had a rigid supinated right foot. The hammer toe and the bunion was not really rectified from the surgery 5 years ago, or no, many years ago, 15 years ago.
Mm-hmm.
And so it was basically center of mass to the right, pelvic rotation to the left, and the right hip was anterior. Once
Mm-hmm.
again, not unusual for that for her center of mass issues. So I did, because she's somewhat tall, I actually put my hands on top of her iliac crest, and I do that generally just to see, close my eyes just to see. And she was really hiked up on her right side. I just noted it down, didn't really say anything to her. So the first thing I did was I actually had her bend forward.
Mm-hmm.
And I was like, just bend forward, let me know what you feel. She's like, oh, I can do that easy. And she did, right to the floor. So hypermobile, right to the floor. So then I said, let me see you squat. and she had no pain with lumbar forward bending. I didn't even check anything else. I said, let me, because I wanted to see how she sat and how she got up from a sitting position first.
Mhm.
So that's why I had her squat. She doesn't, so I don't squat well. I go, you sit in a chair, right? So I literally had her sit, I turned her back. I said, sit down on the plinth. And then I had her sit down on the plinth. I left her there for like 30 seconds. And I said, now, I mean, she didn't have a great form in an unassisted squat, so to speak. But when I put the notion of sitting in a chair, when she sat down fine. When she stood up, I said, now stand up. She stood up and her entire, I can explain this on her, she stood up and her entire body shifted to the left. So not shifted to the left, rotated to the left. So the right hip went forward.
Mhm.
So it was, she went seated she stood up, and it was like shift to the right leg and a pelvic rotation to the left. So I put my hands on her hips. I mean, on her ASIS. I had her sit back down on the plinth. I said, stand up and just note, just tune into my hands. Just see where they go when you stand. And she did. She's like, oh, the right one's more forward. I'm like, yes, that may be relevant. That may not be relevant. Okay. So, and I said, how did you feel? She's like, I felt okay because it was a 30-second stand, basically. I mean, a 30-second sit.
Mhm.
So I said, when you're sitting, when you have to get up, keep your headlights. I explained to her what the headlights were. The ASIs is
Mhm.
forward. Okay. Just try to keep them forward. Then I went into I tested her slump for the driving.
Mhm.
I had her get back down, and I just had her basically slump, and it reproduced her back pain and her butt pain, not her leg pain.
Okay.
So I said, just, kick your right leg out. And I tend to look at this, not because I think there's a lot of neural tension. I mean, ultimately it's the nervous system. I want to see when she's driving, when she's got that right leg out,
Mhm.
is she slumping into that right side more than she is on the left? Or is there more
Mhm.
pelvic motion on that right side? So when she slumped and she straightened her left leg out, yeah, she has tight hamstrings, but she was able to stabilize the pelvis, okay? She wasn't slumping into that left side.
Mhm.
When she sat back up and then I had her slump again and I had her straighten the right leg out, she kicked right back into that right side and then reproduced the whole
Mhm.
kit and
Yeah.
caboodle. So I'll stop there and you let me know your thoughts on that.
Yeah. I
I'll
mean,
move
it's
on.
just it's making you think. Again, it's flexion driven for sure.
Mm-hmm.
I think she's using. To me, it would be that some of these little things that she's doing is to stop the pain. She's kind of pulled herself into this position to do that. There's no telling what the brain is trying to do in its protective mode. This has been going on for a while. She's had a lot to protect for a long time. How did she do with standing with the headlights? You didn't have her sitting for long enough to know, right?
No, no, but
Yeah.
I'll get to that
Yeah.
next visit.
Yeah. So, and then the slumping, that right there, that's the position she has to get into drive. And if it bothers her, just going into that motion without anything else really being that flared up.
Mm-hmm.
Has she done anything in her car to alter
She
that position?
she said she puts a pillow underneath her bum, and I'm like,
Okay.
I don't think you need a pillow under your bum, but that's pretty much what she's done.
Yeah, the problem with a pillow is that it squishes.
Yeah.
So it could be actually adding to it rather than taking away.
Mm-hmm.
If they're going to put anything underneath their bum, I would like a folded dense blanket so that it doesn't lose its shape. But I'm
Mm-hmm.
not sure if and the idea of getting up a little bit may help because that could put her in a different position.
Yes.
But I would think that she just simply needs to bring the car seat forward.
Yes, which is what
She's
I told her.
very tall and long leg, and so she's going to have to bring that seat forward so we can take the tension out of the system. Would be the
Right.
very first thing I would think.
Yeah,
Yeah,
that's what exactly what I told her.
yeah.
Yeah. So I had her just stand. I just did one-legged standing, even though walking was okay. I just wanted to check it. She had pretty poor control on her right side and standing, which is makes sense. I just did it because I did. I just no reasoning behind it. Because usually when I see patients have a problem walking, I'll look at one-legged standing and step forward. She didn't, but I was just curious to see to further sort of solidify my hypothesis. So
Mhm.
So then I had her go down on the table after that, and I just wanted to check some soft tissue because I noticed in standing the erector spinae on her right side were really jacked up, and that is what they were working on, and I want to know why. I wanted to explain to her why that didn't help.
Mm-hmm.
So I had her go supine. I checked her right psoas because sometimes when I see a lot of pelvic rotations, I check psoas and I'll check obliques and diaphragm and all that. And I saw the right psoas was significantly facilitated, and in prone, her right longissimus iliocostalis, all increased resting muscle tone, as was her right hamstring to a significant degree. I've never
Mm-hmm.
seen a hamstring so tight. In prone, in unloaded, it was like a mountain. I've never seen anything like it. It was crazy.
Mm-hmm.
So is that the chicken or the egg? I don't know,
Right.
but
Definitely an over recruitment for sure.
for sure on all accounts. And I just quickly looked at her joint mobility, and lo and behold, that was normal. Of course, I didn't expect any
Mm-hmm.
stiffness there. So what I did the first visit, besides adjusting the car, moving forward, and looking at her headlights, I explained. So this is what I did: a little bit of release to the psoas, and so I detected just from her manner that she was one of these sensitive, less is more types. So I said, I wanted just to give you some proprioceptive feedback to when you're standing, when you have to go from sit to stand, or when you're standing, to
Mm-hmm.
try and keep that right headlight back. So I put a piece of hypofix tape, literally, sort of midline to back by the PSIS, just pulling her back. I didn't put any Leuko tape, nothing, just a little piece of tape just to give her an idea of,
Mm-hmm.
oh, okay, I need to sort of pay attention and not resort to my old strategy. So I explained to her. Oh, I also, before I do that, I actually had her go against, I took a cue from your book. I had
Mm-hmm.
her, I think it was the last podcast we did, I had her go against the wall and with the fingertips against the wall and have her get her weight, do some weight shifting to the
Mm-hmm.
left, which she's been doing. So after that, I rechecked her slump, and it was about 80% better after all of that. And I explained to her that when she slumps and when she's driving, as Shirley Sarman would say, her path of least resistance or directional susceptibility of
Mm-hmm.
whatever, I forgot what that is into that right flexion. So you are having increased mobility into that I call the right flexion quadrant. So when you sit back and you straighten that right leg out, you have a lot of mobility on that right side. So
Yeah.
stretching, massaging, releasing that is only feeding into your problem. You need a new strategy and you need control there. And so I try to explain that. So I'll stop there and let me know your thoughts.
Yeah. No, that's exactly the thoughts that I was having is that we need to if those things were feeding into it and she was laying on her back and doing flexion exercises and they were making it worse, then all she's doing is just driving her symptoms.
Yep.
She's the exercises are confronting an otherwise avoider,
Right.
and it was too much for her. And everything that she was doing was actually pulling her into the pattern that is sensitive.
Right.
And so her brain's protecting like crazy at this point now, which is all the over recruitment that you see.
Mm-hmm.
So she lays prone, she should be able to like turn things off. She can't turn them off. So there's an over recruitment going on for sure.
Mm-hmm.
And so it's trying to pull back as hard as she's trying to push into it.
Yeah.
So she's got a tug of war going here. So I like what you did, because these are the things that uh, she needs to kind of start thinking about, is that she needs some good coordination around that system. Everything's being pulled into it. That would be what Shirley would call the tail wagging the dog.
Right.
Instead of the dog wagging the tail, that she straightens that leg out, the back goes, the pelvis goes, everything goes, and she should be able to flex her hip and extend her knee without having changes in that proximal segment.
Mm-hmm.
We're capable. I mean, we're multi-jointed. We're capable of doing that. Now, there's times when we want to do that, and that's fine. But her sensitivity is really pulling her into that more, and that's you would think it would do the opposite. It would make her go out of that, but You
I
know,
know.
our brain works funny.
I know. It's funny because I always say, did I expect, neural tension or, a sciatic nerve? No, I didn't. But she drives, and that's a slumped position. So
Yeah,
the slump isn't just from, testing the quote unquote nerves. I did it because it was functional. It was reproductive of the
right,
main issue that bothers her.
right.
And so I sent her home. I told her to take some Advil, and she hadn't been doing that. So I did take some Advil. So I saw her yesterday. This is the second time I've seen her. And she said she was feeling a lot better. She still had the tape on. And, I was thrilled because I was trying to explain to her that and I think she was so worried that something bad was happening because she did get
Hmm.
worse. And I was like, well, you got worse because I didn't want to say the wrong thing was done. I said, you just didn't need that you didn't need stretching and you didn't need the release, at least not to your back. Okay.
Hmm.
Maybe, the hamstring, maybe a little bit of the hamstring, but certainly not the back. So
Hmm.
I rechecked her. I took the tape off. I rechecked her slump, and she had just a teeny, increased mobility way at the end of knee extension, very small. And her squat was good. Her sit to stand was perfect, quote
Hmm.
unquote. And I didn't touch her low back in terms of release work the first visit at all. So I said, let me just check and see how that your back feels, because in the past when they worked on it, you were worse. Do you know it had a significantly reduced in tone? And I said it was more of a reactor muscle, as Diane Lee would
Hmm.
say, than an actor. So it wasn't the
Yeah,
cause of the issue; it was a reaction. So when you had got more control back, the nervous system said, "Oh, I can calm that down now,"
yeah.
and let
We've got
her.
other muscles working. We don't need to overwork now.
Correct.
Plus, she was
So,
also moving herself into positions and strategies that were not feeding her pain output loop. So
correct.
her brain didn't have the need to overprotect anymore.
Correct.
It could back the protection piece off a little bit, that
Right.
that overprotective response, pain output response.
Yep.
And if she also wasn't so worried that something bad was going on, that takes her out of threat too. So we know that the muscles themselves and everything can change when we're not under a threatened situation all the time.
Yeah. Yeah. And she's like, should I do any stretching? I'm like, should you want to stretch your hip flexor, stretch your hamstring? Go for it. But I would not stretch knee to chest, cross body, glutes. That's not, obviously didn't help you. So what I did the second visit, I just reproduced. I did the psoas work again. I did a little bit of work in her hamstring. I didn't do a lot. Less is more with these people. And I just stretched her hamstring out, taped her, and sent her on her merry way.
Hmm.
So, because there was so much improvement. And she was going to drive today, actually, as we're recording this. And she was a little nervous. And I was like, if you're nervous about driving, it would have been a significant drive here to Staten Island from Manhattan with the traffic, especially during, we're recording this, it's UN week. It would have taken her at least 2 hours, okay, with the traffic. So she was a bit nervous. I said, if you're nervous, don't go. She didn't need to go. So I said, you can go next week. If you want to just go back to driving, figure out a place you can go to within an hour of here, which sometimes is hard in the city, or drive around, go up to Harlem and back, go downtown, just drive. So she may do that. And I retaped her, as I said, and then I sent her home, and that was it. I did not do a lot. I think with her explaining why she wasn't getting better, explaining that she was going to get better because she had a lack of control, I think was a significant part of her improvement, along with just telling her why she has this problem, right?
Yeah.
And the tape was just, a little reminder, a little
Hmm.
icing on the cake, so to speak.
Hmm.
Um,
A bit of sensory input to help her change her strategies. Hmm.
correct. And I think the reason why I wanted to talk about her is I look at hip mobility and hip. I didn't do that because there was a commonality in the issues in the aggravating features of her presentation. Sit to stand, come from a sitting position, slump. The only thing was standing, when that was really tertiary. So I checked the activities that bothered her. What's
Hmm.
happening in sit to stand? What's happening in your slump? Because that's how you drive. I felt that I was going to glean a lot more than just sitting there and testing hip and range and
Right.
internal and external. And so I think that as therapists, sometimes we need to focus, and I know we all do, but function first. And
Yeah.
at the end of the day, I mean, you're going to really prolong your evaluations. You wouldn't have gotten anything. I wouldn't have gotten anything by testing hip extension on her and
Right.
hip
What you
posture.
needed, so the issue is what they did before
Correct.
wasn't helpful. And
Right.
that's what I always go back to is like, stop putting up with things and pushing through symptoms. If it's not helping, don't do it. Let's find another way to get something done. We need to kind of find the edge of it and figure out where you can move. Is she ever going to flex again? Of course she is. But
Yep.
first you have to get things to settle down. She was in such a uh, uh, irritable state that, all over the place irritable. Like,
Yep.
her brain was irritable, her thoughts were irritable, her movement was irritable.
Yep.
And it was, and she was, and she was just living, and putting up with that and having to like really, she was trying to change it, but she didn't know how. And
Right.
sometimes when we get in with movement, we can say, look, this one bothers you. This is what you're doing when you're sitting in the car. So let's see if we can't figure this out so that you can sit in the car. And
Mm-hmm.
then, like you said, if you don't have to go somewhere, then go for shorter drives and start to build up your tolerance to it.
Right.
Because, sitting for long periods of time still may not be so wonderful, even though she can get up and down from a chair now and do some things a little bit better. It's calming down. So
Mm-hmm.
she's still in that calm phase down thing, which is why I love what you said. If you don't have to go, then why don't you take a shorter drive and just start? You didn't say don't drive. You just said, just test the waters. It's a test retest. That's a motor control thing.
Yeah.
We've got a hypothesis. We think we're onto something here. Your symptoms are settling down. So you do need to drive and do some things, but let's test the waters. Let's do a test retest and see how far you actually can go before it starts to kick in. And then maybe we can problem solve around that. Maybe it's a little bit more positional. Maybe it just is a tolerance thing at this point.
Mm-hmm.
Um,
Yep.
and just getting used to it. But I like the whole idea of, what muscles are actors or reactors. And, oftentimes we find that she doesn't have adaptive shortening of her hamstrings. She has over recruitment,
Exactly.
and the other muscles are just, there's pain. So they're going to over recruit. And it's
Mm-hmm.
just, they're working in the face of whatever came on. And, so we're a accumulation of a lot of different things, but she certainly had a lot of reason to have some central windup around, getting injections in her foot and driving and doing this and doing that. And
Yeah.
all
Yeah.
of those kinds of things. And, she's had some other stuff in her life too. So
Yeah.
that's that central, her protective brain has just gotten a bit overprotective and into this one pattern for sure, which
Yeah.
was really interesting to watch you take her out of it.
Yeah.
You
So,
know,
yeah. No, I I felt like I spent a lot of time talking the whole time with her, but sometimes they
yeah.
need that, and she needs to drive again. So my plan is I'm seeing her, I think this week again, basically just I'll recheck everything. I may just have her do some squats, sit to stand practice.
Mm-hmm.
Uh, Not sure if I'll taper again. Do some weight shifting. If there's anything else you can suggest you want to throw
I
out.
mean, you said that you spent a lot of time talking, and I dare say, I bet you spent a lot of time listening too.
Yes. Yeah.
So you're building self-efficacy with her,
Yep.
and I like the plan is to continue to do the active things so that
Yep.
she has the ability to change her situation
Yep.
and she has the success with it so
Yep.
that she doesn't feel dependent,
Right.
on somebody. She doesn't need, in Pittsburgh they don't say to be, they always, and she doesn't need to be fixed. In Pittsburgh they'd say she doesn't need fixing. you know but
Exactly.
yeah, exactly. But I like that plan.
Yeah.
Start testing the waters and getting her to test movements and
Yep.
understand. Oh, if you feel that, what can you do? And right then be able to start to change it and not just continue to push through and put up with it. Yeah,
Right. Right. Yep.
great.
Yep. And I'll probably add some rotation, but
Hmm.
most of her issues were sagittal, but obviously I'll add rotation. But that's what I plan to do: some squats, a little bit of rotation. I'll recheck, but the reason why I wanted to talk about her was just explaining, the why she wasn't getting better prior, and the clinical reasoning behind that. So
Hmm.
that's that.
The only thing that I would add is that when you see her next time, I'd be interested
Mm.
to know if she stood and crossed her legs and did a bend over, how that would affect.
I can do that.
Yeah, and
I can
because
do that.
if it does bother her,
I may have done
which
that
if right
actually.
over left or left over right, then she
Uh-huh.
can, kind of work at the edge of that range for the neural tensiony part too.
Yeah, it's I didn't write it down, but I may have done that. But if I didn't write it down, I'll definitely check that. Yeah,
Yeah,
yeah.
just a
Yep,
thought, just to
yep,
see if you wind that system up a little bit more, what might happen now
yep, yep.
that it's starting to get better, so you can work closer to the edge of where she needs to
Totally.
get because she
Yep.
is so tall. Hmm.
Yeah, exactly. Well, there you go. Well, thank you, everybody.
Yeah,
Thank you,
thanks for
Susan.
joining us. Stay tuned
And
for our big announcements that will be coming on joining us for some tough to treat stuff. And
yeah, we're trying to get a group together around CSM, right, in
yeah,
Denver in February. So,
hmm
if, if you want to do mastermind for a day or something, please reach out to us and let us know if that would be of interest to you. And if you want to just get on our newsletter, is toughtotreat.com, and we have when you opt in there, you'll get some PDFs that we send out to people who are already on our list.
hmm
So, and I think that's it, right? Yeah,
yeah.
that's it. Perfect. Okie
Okay.
dokie. Thanks,
Thanks,
Susan.
everyone.
Bye.